Very good morning, dear students. So today we will take a class on HIV infection and AIDS. So we will discuss the class in four sections. So we will have a brief introduction. So the details of HIV and AIDS you can refer to other textbooks, medicine or oral medicine, general medicine, or any other textbooks. Then we will see the oral lesions or the oral disease in AIDS and the gingival and periodontal disease in section 3, and we will briefly discuss regarding the management of the same. So AIDS or the acquired immunodeficiency syndrome, the condition which was first reported in 1981, is characterized by impairment of immune system, and it's caused by the virus human immunodeficiency virus. The name of the virus itself says that it leads to immunodeficiency in humans. This HIV virus has a very strong affinity for the cells of immune system, and especially those cells which has CD4 self-surface receptor molecule. So the most profoundly affected immune cells are helper T lymphocyte cells, and apart from this, the other cells of immune system such as monocytes, macrophages, Langerhans cells may also be involved, and apart from that, the neuronal cells and glial brain cells might also be affected. So once a person is being infected with HIV, the virus keeps on replicating in the reticuloendothelial tissues of lymph nodes, spleen, gut-associated lymphoid cells, and in cells of macrophages. There is a continuous replication of the virus. So once a person is infected with HIV and the virus start replicating, and even though many antiretroviral agents and protease inhibitor drugs are available, these drugs might result in less of viral plasma payloads of HIV virus, but the virus is never completely eradicated. The B lymphocytes are not directly affected by the virus, but due to the altered function of T lymphocytes, there is secondarily involvement of B cells, which results in B cells dysregulation and also the altered neutrophil functions. And HIV positive individuals are at increased risk for developing various types of malignancies and disseminated infections with microorganisms such as other viral infections and mycobacteriosis and mycosis fungal infections, and they have increased risk for adverse drug reactions. So this HIV virus is detected in most of the body fluids. They are found in high quantities in blood, semen, and cerebrospinal fluids. And regarding the transmission, almost exclusively by sexual contact or by illicit use of injectable drugs or exposure to blood or the blood products. So we just completed a brief introduction on AIDS. Kindly refer other textbooks for the detail of HIV infection and AIDS. We will now see the second section of the lecture, that is oral and periodontal manifestation of HIV infections. So first we are going to see the oral infections. So there is a strong correlation between HIV and the patient developing oral candidiasis, oral ehrlichioplakia, various types of atypical periodontal disease, oral Kaposi's sarcoma, non-Hodgkin's lymphoma, and the patient might also develop melanotic hyperpigmentations, mycobacterial infections, necrotizing ulcerative stomatitis, and various types of miscellaneous oral ulcers and other viral infections such as herpes and zoster. So the first most common oral infection is oral candidiasis. So even though the oral candidiasis is found in normal oral flora, which is caused by Candida albicans, so this results in lesions which proliferates on the surface of oral mucosa and certain conditions that's opportunistic infections. So the major factor which associated with overgrowth of candidiasis is basically a diminished host response, as seen in debilitating patients or in patient receiving immunosuppressive therapies. Approximately 90% of the AIDS patient will definitely have candidial infections. And clinically, the candidial infection may present in many forms. Say, for example, it can be a pseudomembranous form, erythematous form, or an hypoplastic form, and which is diagnosed by clinical and microscopic examination. Kindly refer oral medicine book for the detail of candidiasis. So it's very important to note clinically that when you see a patient and they have candidiasis and there is no apparent predisposing cause, so be vigilant to get a HIV infection test done. So this HIV patients who has developed esophageal candidiasis, it's a confirmative and diagnostic sign of the patient has developed AIDS. The next common oral lesion in HIV patients are oral ehrlichioplakia, which are found on the lateral borders of the tongue, which has a bilateral distribution, and sometimes the lesion might extend onto the ventral aspect of the tongue. So some of the characteristic of this lesion are they are mostly asymptomatic. They represent poorly demarcated keratotic areas on the tongue, and they have characteristics vertical striations, congruated appearance. When dried, they show an airy appearance, and these lesions will not easily rub off. They do not rub off, and exclusively they are found on the lateral borders, as mentioned, but can be seen on the dorsum surface of the tongue, or sometimes this such lesion can occur on buccal mucosa, floor of the mouth, retromolar area, and even the soft palate. Most of the lesions are colonized by Candida organisms, and the lesions are believed to be caused by human papillomavirus. There is also evidence suggesting that this condition might be associated with Epstein-Barr virus infection. So the differential diagnosis include various types of dysplasia, carcinoma, might be squamous cell carcinoma. It can be a frictional or idiopathic keratosis. It can be a lichen planus or a tobacco-related leukoplakia or a secondary syphilis or a hypoplastic candidiasis. The next common oral infection is Kaposi sarcoma, which is a rare multifocal vascular neoplasm. It's a malignant tumor. The cause is unknown. 71% of Kaposi sarcoma lesion usually develops on the palate and gingiva, and many of the times the oral cavity might be the first or only site of this lesion. In earlier stages, the lesions are painless, reddish, and purple macules will be there on the mucosa. In the later stages, these lesions can become nodular. So the diagnosis is based on clinical and histological findings. And this Kaposi sarcoma commonly occurs in patients with lupus erythematosus, patient receiving immunosuppressive therapy, and in renal transplant patients. So, a lot of other differential diagnosis has to be considered, um, as other hemangiomas, atypical hyperpigmentation, sarcoidosis, or an bacillary angiomatosis, angiosarcoma, pigmented nevus, and cat scratch disease. It's very important to note that this Kaposi sarcoma, in its classical form, it is a localized and slowly growing lesions. But in HIV infected patients, it becomes much more aggressive. So in HIV infected individual, they are likely to have 7,000 folds more likely to develop a Kaposi sarcoma. And once in a HIV positive individual, the presence of Kaposi sarcoma signifies that the patient has been transient to AIDS. So it's also important to know that before the various types of combined drug therapy available to treat AIDS, so if the patient has developed Kaposi sarcoma previously, the median range of survival was roughly around 7 to 31 months. If the AIDS patient was diagnosed to have Kaposi sarcoma, the survival time would be somewhere between 7 to 31 months. So the next lesion which is common in HIV and AIDS patients are oral hyperpigmentations. So there is increased incidence of this oral hyperpigmentation in HIV infected individuals. The exact cause is unknown. The oral pigmentation might be appearing in the form of spots or in the form of striations, and the common places are buccal mucosa, palate, gingiva, or the tongue. So, even though the exact cause for such hyperpigmentation is not known, it might be related to the prolonged use of drugs, um, and combination of various drugs in HIV or AIDS patient. that might result in adrenocorticoid deficiency. And the other possible causes might be a viral infection by other type of virus such as pneumocystic RNA or cytomegalovirus viral infection in HIV or AIDS patient. So the next lesion is bacillary or epithelioid angiomatosis. So this is again a infectious vascular proliferative disease, and clinically and histological features are similar to that of Kaposi sarcoma, and probable cause might be because of rickettsia-like organisms. So variety of non-specific oral ulcerations are found in patients with HIV or AIDS. The etiology might be related with many types of neoplasms which develops in such patients, such as lymphoma, Kaposi sarcoma, squamous cell carcinoma, or HIV-associated neutropenia. So these uh, neoplasms and lesions might produce a lot of non-specific oral ulcerations. And it's also been noted that HIV infected patients have a higher incidence of developing recurrent herpetic lesions and after stomatitis. It's also very important to note clinically that in healthy patients, these herpetic and aphthous lesions are very much self-limiting, and they are quite easy to diagnose based on the characteristic clinical features. Say, for example, herpetic lesions occurs on keratinized mucosa, whereas aphthei occurs on non-keratinized surface. Whereas in HIV infected patients, these herpetic lesions may involve all mucosal surfaces and even extend to the skin, and it might persist for months together. So currently the CDC include that any mucocutaneous herpes which persists for more than 1 month, okay, is a sign of AIDS. So when you're seeing herpetic lesions on the patients, and if it's persisting for a month, more than a month, so we need to suspect or we need to consider the possibility of the patients having HIV and AIDS. So we completed the second section, that is the oral lesion in HIV and AIDS patient. Now we will see in particular the gingival and periodontal disease in our third section of our lecture. So the first lesion is linear gingival erythema, which is seen in HIV or the AIDS patient. These are persistent lesions, appears as linear, uh, which are easily bleeding, and there is erythematous gingivitis. And the microflora of this linear gingival erythema depicts that of adult periodontitis patient. The lesion can be localized or generalized, and this erythematous gingivitis can be limited to the marginal gingiva, or it can extend to the attached gingiva, or sometimes it can extend into the alveolar mucosa. So it's important to know that if a patient is having linear gingival erythema and we do a conventional periodontal therapy, most of the time it's not responsiveness. It doesn't show any responsive to our conventional therapy, and sometimes regression and recurrence might be uh, spontaneous. In the next lesions, the gingival and the periodontal lesions are which are common in AIDS or HIV patients are necrotizing ulcerative gingivitis and necrotizing ulcerative periodontitis. The clinical features are the same. Go back and refer the class on NUG and NUP. You can write the same clinical features. And these necrotizing lesions are very much common in HIV infected patients. The next common necrotizing lesions is necrotizing ulcerative stomatitis. It's a very severely destructive and very painful necrotizing lesion. It's characterized by necrosis of significant areas of oral tissues and underlying wall. It can occur separately or an extension of necrotizing ulcerative periodontal lesions, and these such lesions are seen when there is a severe depletion of CD4 immune cells. Okay, now we will see the last section of our class, the management protocol. So the management, periodontal management, or the oral management basically depends upon the health status of the individual in HIV patient. So the patient health status we can determine from history, physical evaluation, and many a times we require to consult with their physician. Again, I would like to stress that the periodontal treatment decision in patient with HIV or AIDS depends primarily on the patient's general health status. Now we will just consider with an example. Say there is a delayed wound healing and increased risk of post-operative infections are the possible complication in patients with AIDS. So if you are treating a patient, chances of delayed wound healing and increased risk of post-operative infections are and even bleeding are possible. So if the patient is otherwise healthy and they are asymptomatic with a normal or nearly normal CD counts and a low viral bioload, so we can provide a conventional periodontal treatment in such patients. Whereas if the CD counts are extremely low and they are symptomatic with a high um, viral bioload, so we need to follow a very conservative line of periodontal treatment. Before we initiate a treatment, we need to obtain information regarding the patient's immune status. So, say for example, what is the CD4 plus T lymphocyte level at present? What is the current viral load? And how do the current CD4 plus T cells and viral load differ from the previous evaluation? How often such a test was performed? And how long ago was the HIV infection identified? A good infection control measures needs to be taken. It goes without saying extremely um, important to maintain the standard of universal precautions to minimize the risk both to the patient and getting infected to the dental staffs. So before we conclude, we will see what are the goals of our periodontal therapy. So the primary goal is to restore and maintain oral health, comfort and function. The periodontal treatment goal will be basically concentrating on control of HIV-associated mucosal disease such as chronic candidiasis and oral ulcerative lesions. So basically, we need to have a good initiate a good oral plaque control program in such patients. So in most of the cases, we restricted to non-surgical periodontal therapy in HIV raised patient with minimal trauma, even though if the patient is asymptomatic and with a low with acceptable CD for 4 plus count level with minimal viral overload, surgery and even implants has been placed, and but it's better to restrict it to non-surgical periodontal therapy in most of the cases, and with a good supportive periodontal therapy, that is a maintenance phase. Say for example, a short recall interval of 2 to 3 months, and we should be careful when we are administering systemic antibiotic in such patients because of subsequent development of candidiasis, and when we are treating such patients, always it's important to consider blood and other medical laboratory tests might be required to see the general overall health of the patient. And many a times, if you are planning for a little aggressive treatment, we need to consult and coordinate with the patient physicians are absolutely necessary. So as much as possible, restrict to non-surgical periodontal therapy. Good supportive periodontal maintenance phase, and with the best possible ways to have a plaque control. It's also important to consider the psychological factors of the patient, since the patient is now fighting with life-threatening disease, or coping with this life-threatening disease. Most of the patients would have elicit depression and anxiety. So it's better to provide treatment in a calm, relaxed atmosphere with minimal stress. And sometimes the HIV infections of neuronal cells may affect the brain function, which might lead to the outrage dementia by the patient. And most of the patients are greatly concerned with the maintenance of medical confidentiality, and such confidentiality must be upheld. So that's it. Thank you very much for your patient listening, and have a wonderful day.